This is my song, O God of all the nations, a song of peace for lands afar and mine. This is my home, the country where my heart is. Here are my hopes, my dreams, my holy shrine. But other hearts in other lands are beating with hopes and dreams as true and high as mine. My country skies are bluer than the ocean, and sunlight beams on clover leaf and pine. But other lands have sunlight too and clover, and skies are everywhere as blue as mine. So hear my song, O God of all the nations, a song of peace for their land and for mine. This is my prayer, O Lord of all the kingdoms. Thy kingdom come, on earth thy will be done. Let Christ be lifted up till all shall serve him, and hearts united learn to live as one. So hear my prayer, O God of all the nations. Myself I give thee, let thy will be done.
Pendant que vous écoutez ces présentations, veuillez taper vos questions pour le présentateur dans la case Chat de Zoom. N'attendez pas la fin du programme.
Here's how to enter a question in chat. Click on the chat icon at the bottom of your screen on a computer or on the three dots More screen, and then choose Chat on most phones. Select To Charlotte White at the bottom of the chat window and then type from your name to the name of the presenter you wish to respond, followed by your question, and then hit Enter to send the message to Question Charlotte.
Voici comment entrer une question dans les chats. Cliquez sur l'icône Chat au bas de votre écran d'ordinateur ou cliquez sur les trois points plus de l'écran et choisissez ensuite Chat sur la plupart des téléphones. Sélectionnez To Charlotte White en bas de la fenêtre de chat. Puis tapez de votre nom au nom du présentateur auquel vous souhaitez répondre, suivi de votre question. Appuyez sur Entrée pour envoyer le message à Question Charlotte.
Muy bueno, botenabino. Good morning. Salutations au nom de notre Seigneur Jésus-Christ et bienvenue à la deuxième session sur les soins de santé au moment de COVID-19. Nous sommes heureux que vous soyez parmi nous aujourd'hui. Greetings in the name of our Lord Jesus Christ, and welcome to the second session on healthcare in the time of COVID-19. We are glad that you are with us today. Our program on healthcare concludes this week with a review of the impact of racism and discrimination, as well as American paternalism, has had on healthcare systems in both the United States as well as the Congo. We will also have two presentations on the future of healthcare in a post-COVID-19 world. Notre programme sur les soins de santé se termine cette semaine par un examen de l'impact du racisme, de la discrimination et du paternalisme américain sur les systèmes de soins de santé aux États-Unis et au Congo. Nous aurons également deux présentations sur l'avenir des soins de santé dans un monde post-COVID-19. Après les présentations que vous allez suivre, nous aurons un temps pour questions et commentaires. Voulez-vous les envoyer par conversaire à Question Charlotte White ou par email à questions4cmn@gmail.com. Following the presentations you're about to watch, we will have a time for questions and comments. Please send them by chat to Questions Charlotte White or by email to questions4cmn@gmail.com. Thank you. Bienvenue.
And now for our first presenter on the racism issues, we have Dr. Mireille Mimikanda, a retired pediatrician, past director of Health and Disability Services at the Head Start Bureau, past director of Child Protection at Children's Hospital in Washington, D.C., and past deputy director at the National Institutes of Health as director of the National Center on Minority and Health Disparities. Since 2016, she has served as senior advisor to the Dikembe Mutombo Foundation, where she assisted in the launching and management of the Biamba Marie Mutombo Hospital in Kinshasa. She is Haitian-born and holds degrees from American University, the George Washington University School of Medicine, and the Johns Hopkins University Bloomberg School of Public Health.
Hello, it's a pleasure to be with you today to discuss a subject which is very complex and that requires much more than the time that we have together. Our new reality is very different from what it was a year ago, from wearing our masks to having virtual meetings. A unique year indeed. Under the shadow of the pandemic of COVID-19, we are now looking at the consequences of the death of George Floyd and others and the reality of the Black Lives Matter movement. We realize that racism has a great impact on our lives and the way we treat each other. We want to be reminded that there are fundamental truths that are always there with us: our love for God and the commitment to love our neighbor as ourselves. This means not only our next door neighbor, but all the people with whom we come in contact on a daily basis. Yes, things are changing, and change is challenging and sometimes uncomfortable. It requires that we go beyond what we are used to. On the wind of change, 69% of Americans believe that racism is a big problem in America. Even the Webster Dictionary is expanding its definition of racism. We are understanding that racism is more than an individual failing, but rather a systemic construct built by society. We are looking more clearly at the issue of white supremacy, which presupposes that one group is superior to others and deserves to have advantages that the others should not have. Let's look at the definition of racism in Wikipedia. Racism in the United States has existed since the colonial era, and it involves laws, practices, and actions which discriminate against various groups or adversely impact them in other ways based on their race or ethnicity. Formal racial discrimination was largely banned in the mid-20th century, and over time it became to be perceived as being socially and morally unacceptable. When we look at the intersection of racism and health, some things become very evident. What is clear is that racism has an impact on health and that it causes health disparities. Health disparities are not new. What is new is that they present a problem. The American government, through the Department of Health and Human Services, has recognized this problem and discussed it in a series of major reports, starting from the Heckler Report in 1985 all the way to Healthy People 2020, which has specific goals to address disparities. Health and healthcare are distinct but closely related, and they join in creating, with racism, the poor outcomes that we can see as health disparities. Health and healthcare disparities are differences in health and healthcare between groups that are closely linked with social, economic, and/or environmental disadvantage. Disparities occur across many dimensions, including race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. Race is not the only factor affecting disparities, but racism is a major cause of disparities. A major issue in understanding this universe is discrimination. What is discrimination? It's a socially structured action that is unfair or unjustified and harms individuals and groups. The impact of discrimination occurs at both structural, meaning societal level, and at an individual level, which means negative interactions with specific people, like salespeople or even fellow passengers on a bus who move away from you, or the taxi driver who ignores you to stop a few steps beyond you for a white person ahead of you. Discrimination is often measured by either everyday humiliations or major discriminatory events, like being denied a loan by a bank because of your race. As an example, a young black man is familiar with the look of alarm that may show on the face of a salesperson when he comes into a store, and how he may be followed around and repeatedly asked what he wants to buy. Discrimination may be invisible to people who are not subjected to it, but it is plain and very painful to its victims. Researchers have tried to understand the impact of racism and its relationship to health disparities. There are at least 3 big research models. The first one is the study of chronic and repeated stress that racism and discrimination cause. Chronic stress leading to chronic conditions like hypertension, diabetes, obesity, and inflammatory diseases. The second model is the model of social determinants of health. Health exists in the context of the broad environment in which we live. That includes access to good food, water, housing, the quality of schools, workplaces, neighborhoods, and the composition of social networks and relationships. The third model is the brain impact model. The impact of unrelenting discrimination on the brain affects self-regulation and leads to things like hypervigilance and negative coping behaviors like overeating, alcoholism, mental disorders, substance abuse, etc. These outcomes are often seen in populations that are oppressed. Let's look at some examples of issues that lead to health and healthcare disparities. Let's start with a lack of access to healthcare and healthcare facilities. This may be caused by financial constraint or by geographic location. Discrimination would be another example, and we have mentioned it before, but it also includes implicit bias. Implicit bias is a more subtle and sometimes unconscious reaction to a certain group of people. It means how you are treated by a provider of services, who may think that because you are for a different racial group, you cannot understand complicated instructions, and who does not even bother to give you a new type of medicine that works better than an old one. The next example is inferior care. It has been shown that discrimination leads to poor and inferior care. For example, a black woman with a serious abdominal pain problem may be ignored by racist caregivers and denied the pain medication that they would readily give to a white patient. All those examples show what can transpire and how poor outcomes are created. How do we prevent and access or address health disparities due to institutional and individual racism and discrimination? Unfortunately, we do not have enough time to do justice to that discussion right now. But let's start anyway. We have to begin with self-awareness, and we have to recognize our own biases, face them, and be open to them and address them. We have listed 7 steps forward. Let's go down our list. The first step is poverty eradication. This deals with the social determinants that we have mentioned earlier, the environmental, economic, and cultural determinants that accompany the social ones. The second step is improved access to healthcare services. And that's where things like transportation and health insurance coverage come in. The third step would be an increased concordance between patients and providers. When they speak the same language, when they are from the same community and they are culturally compatible, this leads to better communication, trust, and better compliance. Ultimately, better outcomes. Provider training on implicit and explicit bias helps, particularly if the providers and the patients are different or discordant. Improved quality of care. Provider training helps improve quality of care and better leads to positive responses to the specific needs of the patients and community. And now let's address community outreach. The education of patients and the community lead to lifestyle changes and better outcomes. The patients can self-advocate and be the best advocates for themselves. Finally, health workforce development. There is a great need for a more diverse group of providers as the country becomes more diverse. And this has multiple benefits that extend over time and across populations. As you can see, there is much to be discussed and to be accomplished. We have only scratched the surface. I thank you for your attention, and I look forward to continuing this conversation with you at another opportunity.
Yepo wanzambi udi uteba batu bwa kumwenzela mudi muwende mudi mumunene tuyayiboso tumwenzele mudi muwende nemoyo umwe mudi mumunene tuyayiboso tumwenzele mudi muwende nemoyo umwe nentume bengatiliso mudimu wanzambi kawenane bawenji nyabami kwabo mudimu munene tuyayiboso tumwenzele mudimu
our next presentation on the subject of racism and tribalism and the impact on health will come from Dr. Pachio Chianza Mikobi. He is the medical coordinator of the CPC, Congo Presbyterian Community, and medical officer in charge at the Boulapé Hospital.
Bonjour chers membres et téléspectateurs des Congo Mission Network. Je suis Dr Chianza Mikobi, le médecin coordonnateur du département médical de la 31e CPC. La 31e CPC a au total 11 hôpitaux en République démocratique du Congo. Ces hôpitaux sont répartis dans 3 provinces de la République démocratique du Congo. 6 hôpitaux dans la province du Kasaï central, 3 hôpitaux dans la province du Kasaï et 2 hôpitaux dans la province du Kasaï oriental. C'est dans ces 3 provinces où il y a eu des vifs combats et des violences intertribales. Nous citons les combats de Nganza, des chefs Kamwina Nsako, de Dibaya dans la province du Kasaï, les combats de Bakwankenge, de Kankenge, de Mweka, de Luebo, de Chikapa et Kamoni dans la province du Kasaï, les combats de Kabe Kamwanga et de Dimbelengi dans la province du Kasaï oriental. Nous signalons ici que ces combats et conflits intertribaux ont entraîné des vrais problèmes ou bien des sérieux problèmes dans différents secteurs des vies humaines, notamment les secteurs de la santé, les secteurs de l'éducation, les secteurs de l'agriculture, les secteurs de l'économie et les secteurs social. En rapport avec l'impact des combats violences intertribales sur les hôpitaux, la formation des professionnels de la santé et les prestations de services, d'une façon générale, les combats et violences ont entraîné un impact négatif en court, à moyen et à long terme. Pour ce qui concerne les hôpitaux, l'impact négatif est caractérisé par la perte des infrastructures sanitaires pendant les affrontements, par rapport à la formation des prestataires de la santé. Cet impact négatif est caractérisé par la faible production des ressources humaines pour la santé suite à l'insécurité, la discrimination, le tribalisme et la pauvreté de la population. À ce qui concerne la prestation des services de santé, l'impact négatif est caractérisé par la sous-utilisation des services de santé suite à la destruction des infrastructures sanitaires, la migration de la population pendant les affrontements, agression des prestataires sanitaires par les milices, non-approvisionnement des formations sanitaires en médicaments et réactifs des laboratoires par les partenaires internationaux. Et nous signalons aussi que les tribalismes ainsi que la migration de la population pendant les affrontements ont entraîné les différentes épidémies telles que l'épidémie de malaria, malnutrition aiguë sévère, les épidémies de fièvre typhoïde et voire même les épidémies de la diarrhée et également aussi la violence sexuelle. Quant à l'impact de l'injustice en République démocratique du Congo, voici quelques éléments de l'impact de l'injustice. Il y a eu prolifération anarchique des partis politiques, mauvaise qualité de services dans tous les domaines suite aux mauvaises sélections de prestataires, impunité, le favoritisme, la guerre tribale ainsi que la perte des vies humaines. Quant à l'impact de l'histoire du paternalisme américain au sol congolais, ce paternalisme a engendré les impacts négatifs et positifs. Quant aux impacts positifs, il y a eu la dotation de plusieurs bourses de titres, surtout pour la formation des infirmiers en différents domaines. Il y a eu la construction et la dotation des infrastructures en matériel et équipement. Du point de vue négatif, le paternalisme américain a donné les points ci-après. La discrimination raciale, la faible considération et traitement des peuples congolais. Aucune industrie américaine sur les sols congolais et il y a aussi l'imposition sur les plans politiques. Quant à l'impact des simples préjugés tribaux, cet impact est négatif car les tribalismes, les combats et violences intertribales ont occasionné l'injustice sociale, ce qui se traduit par la discrimination dans la sélection des personnels médicaux dans tous les domaines, prolifération des partis politiques anarchiquement et qualité douteuse des services dans tous les domaines. Il y a eu aussi les favoritismes ainsi que l'imputation. Quant à l'impact des combats violents sur la préparation, les traitements de COVID-19, ici nous signalons que ces conflits n'ont pas engendré aucun impact. Au contraire, ils ont entraîné la recrudescence des épidémies, étant donné que le système de la santé est généralement paralysé. Nous allons faire quelques suggestions. Il y a eu des suggestions dites de façon générale et les suggestions en rapport avec le COVID-19. D'une façon générale, nous passons à organiser les cadres de concertation avec les leaders sur la résolution des conflits. Intensifier la sensibilisation sur les effets négatifs des conflits. Assurer l'assistance sociale des personnels vulnérables. Construire les structures sanitaires dans les lieux non couverts. Assurer la formation des médecins et infirmiers en santé publique pour une meilleure prise en charge des épidémies. Assurer la réhabilitation des infrastructures sanitaires détruites pendant les différents affrontements, doter les formations sanitaires en matériel détruit, surtout les frigos pour la conservation des vaccins. Que les peuples américains assurent un bon traitement des peuples congolais. En rapport avec les COVID-19, ici nous avons retenu d'intensifier la sensibilisation en rapport avec les COVID, assurer la surveillance épidémiologique à base communautaire et non communautaire, doter les personnels de la santé en équipement de protection, aménager les cadres d'isolement des malades suspects dans les formations sanitaires et puis assurer la prise en charge financière des personnels médicaux. Je dis et je vous remercie.
Munaitwe chisamba cha mukelenge chisamba chisungula cha bamanyi ne bamwita buji chakapikula kilisto kumashimene chabana bamulayi ibadibashinga moyo unaitete chisamba cha mukelenge chisamba chisungula cha bamanyi ne bamwita bushi chakapikula kilisto kumashimene chabana bamulai badibashinga moyo tusakai tumutile chama nemimwemwe wanina majayeko wanzambi kulibantu chakatukesha moyo wachengelele nashatatu anyimakenga nashalufu kanena kumu yetu wawamwitabuja nashabyakoye neikalele moyo wachengelele wawamwitabuja nashabyakoye neikalele moyo wachengelele tusakai tumutile chama nemimwemwe waninangajayeko wanzambi kulibantu yakachupesha moyo wachengelele nashatatu anyimakenga nashalufu kagena kumu yetu wawamwitabuja nashabyakoye neikalele moyo wachengelele wawamwitabuja nashabyakoye neikalele moyo wachengelele.
Our next presenter, with reflections on the future challenges and opportunities in a post-COVID world, will be Dr. André Jacques Neuzy, the co-founder and senior director of the Training for Health Equity, or the NET project. He is an honorary associate professor of medicine at New York University School of Medicine, where he co-founded and directed a cross-disciplinary center for global health. A leader in health workforce education, Dr. Neuzy has consulted on health workforce development for academic institutions, governments, bilateral agencies, and international organizations. He spent much of his childhood and youth in the Congo, in or near the city of Kananga, where his father was a Protestant chaplain with the army.
Hi. It is a special pleasure for me to be part of this series of discussion. I want to thank the organizer for inviting me. And it has a special significance for me because I have a very special bond with the Democratic Republic of Congo, and more specifically with the province of Kasai, where I spent my childhood and adolescence in the city of Kananga. I am the senior director of the Training for Health Equity Network, or the NET, an international partnership of academic institutions committed to train health professionals with a sense of dedication to serve where the needs are the greatest. Our academic partners are located on 5 continents, and they work across sectors. And what is the common thread between them is that they are community engaged and work with the community they serve, with a focus on the underserved. COVID-19 has hit an unequal world, riddled by inequities and inequalities, and it is not only a health crisis, it is a human crisis affecting the very fabric of our society. It has highlighted the existing inequalities not only between industrialized nations and developing countries, but also within wealthy countries where racial minorities and lower social economic classes are disproportionately affected as a result of ongoing discriminations that prevented them from having fair opportunities. This pandemic is a massive challenge. It highlights the urgency for a multi-sector approach needed to align and coordinate health systems with other sectors, such as public health, social services, education, transportation, sanitation, and other essential utilities frequently undersupplied in poor countries. The pandemic also caught our health systems unprepared. Poor, under-resourced regions with feeble health systems have been hit particularly hard. Our organization, the NET, primarily focuses on the education and retention of health professionals in areas of need, as I mentioned. But it has long recognized the need for a more effective integration between education, health, and social systems, whether in developed or developing nations. We work with partners in different African countries, including the Democratic Republic of Congo, where we collaborate with 2 universities located in the eastern part of the country, in the province of South Kivu, in the city of Bukavu. They are the Université Officielle de Bukavu, or the State University of Bukavu, and l'Université Évangélique d'Afrique, or the Evangelical University of Africa. In 2018, at their request, our organization conducted an assessment of their priority need, the needs of these institutions. Both universities have a School of Medicine and Health Sciences and a teaching academic hospital. These 2 hospital centers are the most important referral healthcare facilities for the city of Bukavu and the entire province. They provide the education and clinical training to future doctors, nurses, midwives, public health officers, and other health professionals, as well as they deliver the medical care to their population, carry out research, and public health activities. The evaluation revealed how the lack of a stable source of electricity affects negatively the training of healthcare professionals, the development of their own faculty in their teaching duties in the hospitals and other clinical sites, as well as the delivery of healthcare services themselves. These institutions, as you very well know, share similar conditions as those in the rest of the country. The majority of hospitals and universities in the DRC face the same issue, namely an unreliable provision of essential utilities such as electricity, drinkable water, the disposal of biomedical waste, and access to broadband internet. These utilities are essential to ensure the good functioning of health systems and educational institutions. Of course, for example, the 2 campuses in Bukavu and their hospitals are frequently facing daily interruption of electricity, making them dependent on costly and polluting diesel generators. This has a direct impact on essential services, such as the maintenance of cold chains for vaccination, the functioning of laboratory services, and the functioning of clinical equipment necessary for patient care. The lack of a steady supply of electricity impacts negatively the development of the IT infrastructure and the development of digital platforms vital for public health surveillance systems. Public health surveillance systems, particularly these days, require accurate and timely data collection and analysis, and the capacity for sharing vital data locally, regionally, nationally, and with the rest of the international global health community. At the time of COVID, lives depend on building an effective online surveillance system. And it is essential for these educational and health centers to have also the capacity to develop and implement e-education, electronic education, and electronic health, e-health programs. These institutions also lack adequate libraries. Their libraries are grossly inadequate. And in the midst of COVID-19, they still don't have a safe water and sanitation system that is essential for preventing the spread of disease. The hospitals and clinics also lack a safe and adequate biomedical waste disposal system. So, to address these priorities, our organization, in partnership with our two local partners, these two universities, and with a French non-for-profit organization called Scale, have developed a project in collaboration with local and international companies and other partners, with the support of the Congolese government, of course. These projects consist of a feasibility study of integrated and replicable legal and contractual solutions aimed at achieving an economy of scale in providing essential utility services that are technically and economically optimized to meet priority needs of the health and educational systems of the city of Bukavu. The project will provide the necessary infrastructure for academia, local authorities, and healthcare providers to benefit from digital advances and online resources. By having access to stable and sustainable energy, local partners will be able to strengthen data collection, analysis, and dissemination, obtain diagnostic tools online, in particular by using artificial intelligence, enable students, teachers, and healthcare providers to participate in online and distance learning activities, to have e-education and to have e-health, and to have access to an electronic library. Integrated and decentralized infrastructure management will strengthen local and global coordination, will strengthen preparedness and response to pandemics and other disasters to come. The COVID-19 pandemic underscores the need to rethink the concept of health in the larger societal context. A big lesson from COVID is that this pandemic is exacerbating the disparities and the inequities in health outcomes. It has the heaviest impact on the lives of people living in deprivation or facing difficult socio-economic circumstances. Socially and economically vulnerable populations, as you know, suffer disproportionately. Let's remember, this is really important, let's remember that good health starts in the community, not in the clinics, nor in the hospitals. In the long term, we must reconsider the kind of health system that is capable to protect everyone, whether in time of crisis or not. We need to rethink what is a health system that works for all by moving from inpatient hospitals to strengthening primary care in the communities where people live. We must make smarter investment, moving from spending big dollars in hospitals to where it counts most, the community. We also know that health is determined to a large extent by what is called the social determinants of health that are responsible for 90% of individual longevity. For example, housing, food, education, access to water and sanitation, employment, transportation, and so on, are determinants that really are responsible for 90% of the length of the time we will spend on this earth, whereas the biomedical determinants account only for 10 to 15%. To tackle these and to tackle these health inequities, health professionals must develop alliances across sectors and work proactively with community partners. Lastly, I would like to share a couple of reflections with you. We can all see that the measures needed to be taken to stop this pandemic will not work in isolation. They will require global solidarity and global cooperation. We are only as strong as the weakest health system in this world. We also hear that there is a so-called post-COVID new normal, as if context doesn't count. We must recognize that poorer countries face their own specific issues, and they cannot be prescribed by wealthier countries actions that don't fit their context. Public health and social measures have demonstrated that they are effective in limiting the spread of COVID. They are physical distancing, local lockdown and confinement, schools and business closure. But their direct applicability in many poorer countries, where economic and social conditions are widely diverse and dissimilar from ours, their applicability remains unclear. African countries must be supported in generating the evidence, their evidence, in their own context, to develop their policies and strategies to limit the social and economic disruption caused by the pandemic and prepare for the next crisis. COVID is a precursor of things to come, and this thing will happen. However, I remain optimistic for the future. The COVID pandemic is an historical opportunity for change. It is an opportunity to get rid of the old normal, and in this regard, the Sustainable Development Goals agreed by the United Nations are paving the road to build a better, more equitable and sustainable world where no one is left behind. Thank you very much. Merci. Voie creative.
Binolingomba ya Amerika Buzalili kono nangomba Buzali solo como nanam Namiso ya bato yonso Buzali solo como Namiso ya bato yonso Lebele ya bato Bazini bino Bazali kotala bino Amerika popelisa Mwindana bino Katina misala malamu Ebele ya bato Bazindi bino Bajali kotala bino Amerika bopelisa Mwindana bino Katina misala malamu.
Our final presentation with reflections on future challenges and opportunities in a post-COVID world will come from Dr. Serge Makolo-Kazadi, current director of the IMCK and chief director of the Chikaji Health Zone, and former medical director and chief medical officer of the Bilomba Health Zone. He has a medical degree from the University of Lubumbashi, a diploma as specialist in public health from the University of Lubumbashi, and a certificate in scientific research from the Free University of Brussels and the Catholic University of Louvain. He was born and raised in Kinshasa, and he is married to Mrs. Berthe Chilomba and is father of 5 children.
Hi everyone. My name is Dr. Serge Makolo. I'm from the Democratic Republic of Congo. I live in Kananga. I'm the director of IMCK, which means the Christian Medical Institute of Kasai. It includes 4 main departments. The medical department with a hospital and a polyclinic, the education department with 2 nursing schools, the community health department, and the hydroelectricity department with a dam. My presentation will focus on 3 points. First, on our healthcare system profile before COVID-19, then on the opportunities of our healthcare system after COVID-19, finally, on the challenges of our healthcare system after COVID-19. To begin, let's look at what our healthcare system was like before COVID-19. I'm going to talk about 2 key aspects: the universal health coverage and the financial protection. Several reports reveal that more than 70% of Congolese lacks access to the essential healthcare services, both in terms of geographical and financial accessibility, especially mothers and children. According to WHO, there is a lack of qualified staff, a lack of medical equipment and materials. For example, in my province, we don't have a surgeon. In my country, before COVID pandemics appears, we had only 50 resuscitation beds, while in Algeria they had more than 2,000. We had only 10 respirators, while in Morocco they had more than 3,000. Evidence shows that in DRC, the majority of the staff have symptoms of burnout. Their mindset and behaviors are affected. The government resources allocated to the healthcare organization is about 10%, and most of Congolese have to pay around 10% of their household budget in healthcare, so that the catastrophic health expenditure is estimated between $20 and $40. In this context of gap in health service coverage, the COVID-19 appears. Like a storm, it sweeps everything in its path. People get ill and die. Schools close. Employees lose their jobs. The healthcare system is under pressure. COVID-19 exposes our healthcare system weaknesses. There are lessons learned from this pandemic of COVID-19. It's very easy to lose the hope. over this negative event. This is the dark side of COVID-19. But let me tell you something. Every coin has two faces. And also, crisis is often what drives successful change. I mean that at every tragic situation, it's very important to analyze the situation for a better future. That's what I would like to call the upside of COVID-19, the opportunities of COVID-19, or the bright side of COVID-19. We have to ask to each other this question: what worked and what didn't work? Today, we are able to manufacture masks, to manufacture respirators. We can meet virtually. Like a mirror, the COVID-19 pandemic opened our eyes, not only to show us our weaknesses, but also to discover our abilities. We are able to teach online. Behind these opportunities, there are many challenges. How can we improve our healthcare systems as long as the majority of Congolese cannot access to the basic health primary cares? How is it possible to improve our healthcare system when we have no surgeon? How is it possible to improve our healthcare system when we have no qualified member, when we have a lack of medical equipment and materials? But let me tell you two things. There is a light behind the COVID-19 pandemic tunnel. And also, just because something is difficult, it doesn't mean it's impossible to do it. God bless us. Thank you.